and welcome to what is the 8th in our series of pop-up ecosystems. My name's Andy Bleeden. I'm the Director for Ecosystems and Membership at the European Connected Health Alliance. We've got an exciting area today to explore, that of a question of around the field of data and data donation, and also what's changed in COVID times. Just a little bit about ourselves to start off. For those people who are not aware who we are, the European Connected Health Alliance are a member organisation with about 750 member organisations globally, all involved with the field of digital health. These range from academic organisations, large companies, small companies, voluntary groups, as well as other industry players, SMEs, and health and social care providers, and the whole gamut of people who are involved with digital health. We also are connected with around 16,500 professionals in the health field and health and social care field. And we're a not-for-profit organisation, and you can see the types of programmes we're involved with below. We get involved with European funding, we get involved with global partnerships and initiatives such as the Digital Health Society. And as I said at the beginning, we're a member organisation. By becoming a member of the European Connected Health Alliance, you can see some of the benefits there, and we'd encourage you to join us. Many of the people speaking today are members of the European Connected Health Alliance, and you can see the benefits in front of you there. We've just started a programme of funding and collaboration opportunities for our members as well. So there's a whole range of reasons to join us. When people ask me what we actually do, one of our products as such, I always talk about, is our ecosystems. Our ecosystems are permanent multi-stakeholder gatherings of health and social care professionals who are there to break down silos that exist in health and social care, transform health and social care delivery, as well, and importantly as well, to create economic opportunities. These are permanent, so this isn't a project. These have been going now since 2011, 2012, and I remember joining the first one of these. But for now, because of COVID, these are online. And no better example of a way of transforming health and social care we've seen during the recent months with COVID. And we've got a series of these and a programme of pop-up ecosystems. And they include all of our ecosystems, which as a network is growing rapidly. We've just launched our latest ecosystem in Lithuania. We've just announced recently our partnerships with Italians, which some of you attended our previous ecosystem will have heard from the colleagues in Treviso. But as I said, these will be online for now to include as many of our ecosystems and our members as possible. But you can see the breadth of our ecosystems in front of you there, and the global reach of our network. Our program at the moment is developing and has been running now. This is, as I said, as our 8th in the edition. Our next will be an exciting venture for us, which is linking up the best of Europe and Canada to look at the area of isolation with our newest to be launched ecosystem there in Montreal, Quebec. So we're quite excited about that. And then we've then got a very pertinent, for many countries, pertinent pop-up ecosystem, which is talking about how different countries and members and ecosystems have tackled the whole area of matching supply and demand. And you can see the dates there in front of you. And please welcome you to register for these. They're free events for you to take part in. And then we're building a program because we are firmly of the opinion that we will not be having face-to-face ecosystems for some time now. And so the need is to build up that program. And we've got an exciting range of ecosystems planned now with our colleagues in Australia, Latin America, and then across Europe. In Northern Ireland, we're going back to the issue of mental health, but we'll also be featuring input from our newest ecosystems, which are still in negotiations to launch in India. We're really pleased to be going back to Greece in September, as well as doing a feature in the Highlands and Islands and in Lithuania. And then last on the list, and this is me hyping it up a little, we'll be introducing the area of tackling isolation in Canada with the input from the Canadian Space Agency and hopefully the European Space Agency. which is about as big a bling as you can put on a pop-up ecosystem. But the issue today is data donation and what's changed. Lots of people have talked about the use of data for tracking, managing symptoms, sharing information, staying in contact. And the interchangeable use of the word data sharing and data donation has moved as people have become more aware of what data they can track themselves, and also have taken steps on their own to share that data. So what we brought together today, I think, as an exciting program of speakers to look at different aspects of our data donation, whether it be the high power computing potential of a Google type enterprise to track our movements and our contacts, to self-managed applications that upload our data and share them locally and regionally as well. Our program today will feature, quite excitedly, Bleddyn Rees, who's our Deputy Chair of European Connected Health Alliance and also involved with the Digital Health Society. We've got from our newest German ecosystem, which we're very pleased to see from the Medical Valley, we've got Professor Jochen Kluchen. We've also got Karina Dantas, who works for European Connected Health Alliance and also for Caritas Coimbra from Portugal. Great to welcome back Liz Ashwell-Payne from one of our members, Orca, who will I think is going to provoke some a different feature for today. And then lastly and not least, certainly, are really pleased to welcome for the first time our Finnish members, VTT, and we're welcoming Kari Kotomaki from VTT in Finland. So that's going to be it from me today. I've got great pleasure to introduce our first speaker now. I'm going to hand over to Bleddyn. Bleddyn, if you could activate your screen, I shall turn off my screen sharing. And I'll introduce you now. This is Bleddyn Rees.
Good afternoon, everyone. Bear with me while I just start the presentation. Okay, we're good to go. So good afternoon. I'm an international healthcare lawyer, and Andy's given you a bit of a description, but today I'm wearing my Digital Health Society Director hat. And what I'm going to try and do is do some scene setting for the other speakers. And the first thing I'd like to talk about is the quote that I put up, which is digital health should not be a gateway to dehumanize care. And what this is really about is it's saying that when we look at data, we need to be increasing access to care, decreasing disparities, not excluding patients and people, and decreasing access and increasing disparities. So what is health data? So I thought I'd state some of the obvious, but perhaps some of the things that are not so obvious. So what are the sources of data? So most people will think of hospital records, they'll think of their GP records. Not everybody will realize that pharmacy keep quite extensive record on drug prescriptions that we all receive from time to time. Less likely for some people is clinical trials and research data. And then I've got growing consumer generated data. So those of us who have an Apple Watch, a Fitbit, a Garmin, whatever the device may be. And then private sector organizations that collect data, particularly industries like pharma and medtech. But the one I wanted to emphasize really on this slide is the aggregated public health data. So it's impossible, unless you've not been watching the television in your own countries, not to have been seeing the references to the R number, to slides and screens shots. And it's demonstrated how much that whole world of data has suddenly become critical to our everyday lives about whether we're going to get locked down, how long for, whether we're going to get released. So that's one of the big impacts, I think, interest in health data and aggregating data across borders. So is it hype? And I thought I'd go back to when the phrase data is the new oil started. So I picked some uses from some companies going back to 2006. But the one I wanted to pick up on there is 2016, when a health analytics expert in the UK from the East Kent University NHS Hospital Trust started to use it. And actually he uses it as a bit of fun in the sense that how real is it? But I think the point that I'd like to make is that when you think of banking, you just do banking digitally. You don't hear people talk about digital banking, but you hear people talk about digital health. And why is this? And in my view, it's because healthcare is remedial in its use of digital and data analytics. In 2017, we set up for the Estonian government, when it had the presidency of the European Parliament, the Digital Health Society, which is really all about data. And they have something called the X-Road, for those of you who don't know. So this is a digital platform that delivers all public services. So what are some of the issues that I'm sure some of the speakers are going to talk about from time to time? Well, one of them is the barriers, if you like, are information silos. The fact that databases can't and are unable to speak to each other. Data can't be exchanged. This is the technical term called interoperability. And then security. And in the healthcare context, because of the sensitivity sometimes of data, we forget that the physical security has also been a problem. So there's lots of examples of laptops being left on trains that are unencrypted with patient information on, or organizations selling buildings and leaving filing cabinets with patient records in. Both of those are real examples where there have been fines from the Information Commissioner in the UK. And then the whole question of privacy. And then one that's often overlooked, which is this about access. So some people, their connectivity or their digital literacy may be a barrier to being able to use data. And then ethics and public-private sharing. But evidence is the one that I wanted just to draw a line under, because in the past, the problems about scaling are often about having to create evidence that the services work, that they save money, or that they're secure, which has been a big barrier for many initiatives. So what's happening in Europe at the moment? So it's really active, partly because we have a new commission framing new policies for the next multiple years. And I'm not going to talk about too much about the detail. Safe to say that there are two really things going on here. One is a European strategy for data across all sectors, and the ethical, if you like, strength that the European Union wants to adopt by saying that the way in which data is collected, used, must place the interest of the individual first in accordance with European values, fundamental rights and rules. And interestingly, that drives their focus on technology that works for people, that has economic benefits, that is fair and a competitive economy, but that does not undermine the open, democratic and sustainable society. And then the second really big initiative is this common European health data space. So nobody quite knows what exactly this will mean, but generally speaking, it's about trying to ensure that you aggregate data across borders, so you drive up learning faster to develop new services, improve outcomes, make healthcare systems sustainable. So the initiatives to watch, the Digital Health Europe project, which Karina will be speaking about, so I'm not going to say anything more about that, but two other initiatives that are pan-European. The first is All Policies for a Healthy Europe, where both the ECH Alliance and Digital Health Society are involved, and we lead the data working group. And the core concept here is the idea that in all government policies, that healthcare should be specifically included, and that it's not a silo, recognizing that health has so many determinants that are outside of what people would regard as the traditional health boundaries. So think transport, think pollution, think asthma, COPD as an example. And then the EU Health Coalition, which we also helped form getting on for 2 years ago now, was the 36 European health organizations involved in looking at how to ensure that the European Commission retained health as a priority and didn't cut the healthcare budget. And there's a report with 20 recommendations. One of the things I'd say is that clearly the pandemic has meant that healthcare has never been more important, never been higher on the agendas of individual governments and frankly, the global community. So some pandemic needs that I'm sure most of you will have been coming across. So data to track the number of infections and inform public health actions. And that was all the graphs and the illustrations that you'll have seen in the many press conferences from different governments. The idea of track and trace apps, and data to develop clinical protocols and treatments. So what some people want to realize is that very quickly, once the first cases were emerging and clinical protocols evolved, data was absolutely critical to developing those treatments and protocols. And then clinical research data. So all around the world, everybody is trying to provide better and better real-time antigen and antibody tests. And as well as the fact that so many services were cancelled, such as outpatient appointments or GP appointments, and having to work out how could you keep essential services running. So some comment from me. I've always believed that healthcare knows no borders, and there's been a clear failure of national, European and global planning. So if you think of things like green routes, which was to try and keep supply chains open in Europe, and when countries closed their borders, the supply chain planning, the shortages in PPE, in ventilators, and in drugs, and the ingredients for drugs are perfect illustrations. The global coordination and solidarity and leadership failures are probably best illustrated by the attacks that WHO has come under, and the fact that countries appear to be doing their own thing and are not collaborating, certainly in a European context, in the way that you would normally have expected them to do. And this leads to the sort of Commission's conclusion that improvement in the resilience of health and care systems is urgently needed. So what sort of solutions have I been seeing? Well, obviously the widespread use of digital meeting software, Teams, Zoom. This is obviously a prime example of the uses, but hospitals are using them for management meetings, to have appointments with patients and others. And it's been great to see governments eventually fast track procurements and start to illustrate and demonstrate to the industry what their needs were, as well as accelerating trials and producing device exemptions in order to develop really fast digital solutions. So next, symptom checkers and virtual assistants. And I'm sure that quite a few people have probably been using some of these, but I suspect that many more of you have been using apps, and quite a lot of you, I suspect, were using app libraries. And that Liz is her area of expertise, and she'll talk to you about the the Orca COVID site, I'm sure. I wanted to mention in passing the C19 COVID symptom checker, which King's College London have produced, which I use, my wife used, most of my family use actually. And there are 3.9 million people who are effectively answering questions, donating data. And it's been very interesting to see how over time that information has deepened and widened. And then finally, I'd have a look at the DHI global examples of COVID-19 surveillance technology. So this is a deep dive around the world by DHI in Scotland, looking at the various technologies. It's on their website and is a good source of information. So in conclusion, will these digital solutions stick? How many of them will survive, if you like, the return to normality? Will the digital solutions be lost? Will the fast deployments continue? Will we still see learning by doing, or will we revert back to substantial evidence-based requirements and pilots that are never scaled? And I leave you with a quote from Rachel Dunscombe, that COVID has taught us much, and morally we must learn and improve based on what we have experienced. And with that, I'll hand back to Andy. Thank you very much indeed.
Thank you for that, Blevin. Very interesting, very provoking, and certainly for us is a good way for us to start off. this discussion. What we've been seeing is a very, very large interest in data. And just for a bit of background, and this will just come for a bit of a, I think we've had one question in already about why we're focusing on data donation and not sharing. And the answer lies with the organization that are on next, which is the Medical Valley ecosystem. We reached out to our ecosystems and asked them what they would like to see as subjects for upcoming ecosystems. And when we spoke with Medical Valley in Germany, they said, yeah, we'd like to see this the concept of data donation and what's changed. So I also think it's good to listen to other people. Obviously, there's a lot to discuss today around data sharing and data donation. And again, that's the question, you know, what has actually changed? Now, I'm pleased to introduce our next speaker, Professor Jochen Klugen from the Medical Valley. As I said, is our newest ecosystem in Germany, which is great to see. We're building our network of ecosystems there, which is vital. And it's very exciting for us because obviously we've got a German presidency of the EU starting in just over a week's time. So I'd like to welcome Jochen over to you. If you could turn on your camera, please, and share your screen, please. Thank you very much.
Hope you can see me because
yes.
It tells me I have turned it on. So hello, everybody. Especially thank you for giving me the opportunity to present you some insights from Germany, or what we are currently doing here in Germany, and how we experience the effect of COVID on this aspect of data donation. I'm happy to join this group here, and I'm just what I learned from the first talks or presentations, introduction. I'm very excited about being part of this group. So I'm Jochen Klugen. I'm a doctor, trained neurologist, and I usually say I'm currently specializing in digital medicine, but this specialization doesn't exist yet in medicine, so I have to kind of build it. So in a way, I work in a very complex surrounding. At the Medical Valley, I'm supporting technology companies who want to enter the German market, but I'm also having a position at the university hospital where I actually see patients and do a lot of tests and clinical studies with digital tools in these patients. And I also have a Fraunhofer position. It's also a non-profit research organization in Germany. I think most of you know, which really tries to understand how technology can help patients. So it's really this spanning between new technologies, in particular patient-centered apps, and I will come back to this later, how we connect them also with the human beings, with the patients and the healthcare provider. This is really my interest. And we are, for those of you who don't know the Medical Valley, we are some kind of cluster management organization here in the northern part of Bavaria. And we are just recently became the digital health hub in Germany in light of the digitalization initiative of the German government. So we are kind of in charge of all the digitalization in medicine endeavors. And we have a lot of industries and also research academic institutions that are summarized here in this Medical Valley area. So in this area, I'm happy to be a doctor to think about digital needs of patients and to understand how technology can help patients. And I will give you just a little bit of my view of what will be the future of digital health or digital medicine, not only in Germany, but I give you some thoughts about the German situation. And of course, one aspect is really the big need for data, and my first presentation actually mentioned this. And where is this data coming from in the future? Well, we have these smart devices, the wearables, the sensors that give us objective data or outcomes. We have patient-reported outcomes, so smartphone or other app-based information. And of course, we have the medical data pieces of the regular classical healthcare system. And what we do right now, we put it all into one or several big clouds. And my vision is that in a couple of years, we will use this data not only for research, which a lot of course, people are doing right now, but we also will use it for care. And I think, in particular, when I look at the technologies, what is driving this vision is not just Corona. In Germany, it's really the new Healthcare Act, and I think most of you heard about it. And this really is a new, just this year started, new act that gives us the opportunity for patient-centered digital services to get reimbursement by the healthcare insurance, which actually makes Germany the largest comprehensive healthcare market on a global healthcare market with over 70 million people that would follow this Healthcare Act once your technology reaching this. So this is, of course, in addition to Corona, substantially changed the view we put on, we have here on medical data, because it even more emphasizes the need for data. But on the other hand, it focuses on patients. This is very new in healthcare, and I will not go into details what that means, but it's also a very important aspect that the patient moves into the center, because the reimbursement happens if you improve the patient's life and not the doctor's life. So that's a very fundamental aspect of change here in Germany. But let me move to this wording we have chosen here, medical data donation, and I just add a little question here to it. What is it actually, and what's the problem around it? Why don't we just do it? Because we need this data, right? And I think as a doctor, I see here, I want to make this analogy to, let's say, non-digital or analog donation, organ donation. This is a situation which, of course, also has a lot of problems around it. You know, do you want to donate your organs or not? But from a process point of view, it's very simple. There is one organ being donated. It will be received by one patient, and hopefully the patient is happy. And this whole concept is very nicely connected. So the person who gives the organ knows that another person will receive the organ and hopefully will get better. So there's a very individual feeling of that. And of course, there are some fears about, well, do I really want to give my organ? But the expectation is quite clear. One person will get my organ and will be happy. So how about data donation? I tried to make this analogy a little bit. So we have this medical data around one single patient, and we expect him to donate his data, so to give it to someone. Here's a problem. It's not only one piece of data that happens, but we can copy it easy. That's very different from the organ. We can't copy an organ, but we can copy data. So all of a sudden, this dual situation of the donor and the recipient is lost. And there are a lot of aspects come into place, and we just heard some of them, but I just want to add them here. So these multiple copies ask the question, who actually owns this piece that has been donated? And a lot of fears come up, and the medical benefit, which is kind of evident in organ donation, becomes less and less evident, and people start to be scared about other things. Transparency, monitoring in a clinical setting versus surveillance in a societal setting. And you know, in Germany, we do not have so good experiences with surveillance, so it's a very important aspect in Germany. Of course, it's a global aspect, but it's very relevant here. And safety, security, privacy are only some aspects of that, but they have to be considered. So all of a sudden, from a clinical point of view, the nice thing about organ donation to be easily transferred to data donation, for me, is not such an easy thing to do. And this is interesting how Corona comes into this, let's say, dichotomy between risk and benefits. And I like to raise these points because, you know, when I'm trying to help technology companies to come into that market to help patients, I'm quite sensitive to see what patients think about it, what's the public awareness of all what we do here. And for me, the big question is, how does COVID change the perception of data usage for research and medical benefits? And I think one aspect that I see in Germany in the public discussion is that the aspect of research becomes much more into the public awareness. It moves into the awareness. People discuss, oh, there's research needed to understand how we can make use of this data. It's not just there and then it's useful and everybody benefits from it, but we really need to understand what is good or bad. And you know, the COVID tracking app, I think all of you know it. And there's a lot of questions now raised. Does it really work? Is it really beneficial, or does it cause more problem? So the awareness of research around medical data becomes much more in the center, and not only the question of safety, security, privacy, and risks. All of a sudden, how can it help is a question that is debated in the community. The second aspect is really that people start to look, what is actually the benefit of this data usage? And this is, you know, a lot of healthy people usually discuss these aspects, and they're scared that there's, you know, you give the data somewhere and somebody takes it and abuses them or misuses them or whatever. But when you talk to patients, they are very happy to participate in any research trial because they feel still part of society, and their responsibility is to contribute with research, with their data to some extent, because they have an expectation to the individual benefit. And that's very different from the banking, digital banking example that we heard before, because the benefit of digital banking is mostly for the banks and the companies. The benefit for digital medicine or digital health is actually ending up in patients that, you know, get less infections, die less. You know, all of a sudden a very big individual benefit comes into the discussion. The third aspect, which I really find interesting, and I think one of the questions that have been raised already addresses this, is the question of centralized versus decentralized data. And for those of you who don't know it, but maybe have followed the COVID tracking app, there was a huge debate, I mean, in particular in Europe and also in Germany, if this data should be stored centrally, so you donate it to someone, or if it is kept decentralized on the smartphones of the users. And actually the last part happened, and this is something which I really like, and I want to stress this point a little more, but I think this is also great that society gets an awareness of what does it actually mean in terms of data donation. So my point here is really, do we need to donate our data, or do we need to donate the access to our data? And somebody who asked this question talks about sharing here. And I think this is exactly the point. So what is the problem if we donate it? Then the data goes into a cloud somewhere, and then of course we can protect it quite nicely, you know, make it safe and secure as good as we can with some mistakes. But the problem is we don't own this data anymore, and then we want to use it for research in different data lakes or electronic health records for integrated healthcare. But why don't we change this? And this is what the Corona app, the tracing app, is actually doing here in Germany, and it has started since 10 days about, that we do not send the data centrally, but we keep it at each patient. Okay, the data stays at the patient. So what do we have to do then? We have to secure the data, of course, on each patient's side, but then we have to control the access to this data. And this is what actually happens right now in terms of this app. So this is a second aspect that Corona is driving. We communicate between the data directly, on demand, and by purpose. So the purpose is, as soon as you get an infection, you use the data and share it, but only with the people who might be also affected, and you do not put everything that has been recorded somewhere. So I really like this concept of decentralized data here. And this is really the point that I think when we talk about data donation and the perception in people, we should rather talk about data access donation, because that preserves ownership. And the only thing what we need is a technical solution for that. And this is what we currently are establishing here also with the people from Fraunhofer at the university. And we actually have these kind of technologies and developing them to really fulfill the idea of making data available, but still preserving the ownership and the we call it digital identity. So summarizing this for me is really, what are the positive sides of COVID? You know, it's of course a tremendous situation, but there are some aspects which I see are really supportive for digital medicine. Of course, the first aspect is really the use of tools. People use it because they want to have a benefit, and they do not feel only surveilled and monitored anymore. The second aspect is, of course, that we start talking about personal medical benefits much more, and not only about the risks associated to data, etc. So this is, from a doctor's point of view, for me, something very big and important that is changing. In particular, when you talk to patients that say they can't understand the public discussion about safety and security, they want to have been helped. They would like to be helped. So please use the data. So it's really an aspect. And of course, the last aspect is that we see new technical solutions, not only governance and regulatory aspects like the GDPR, etc., but we see new solutions that maintain privacy and maybe something which you can call digital sovereignty. And this is really what drives me also as a doctor thinking digital into this aspect. And with that, I hope I give you some ideas about what we do here in the Medical Valley area, and also with Fraunhofer and companies. But I think this is really a fundamental aspect of data donation, understand donation rather as an attitude of people than a technical solution. And I think if we do this, then the word is well chosen. But as I said, it should be maintained with the user and the patient and not shared by anyone due to copy problem. Thank you very much.
Thank you very much for that. Very interesting and very thought-provoking, especially the idea about access donation. So thank you very much for your presentation. I think touches on some very interesting concepts. And as I said right at the beginning, this was a very welcome intervention from our German ecosystem when I threw the challenge down on what would you like as a topic. And then we've actually seen that being discussed and debated here, which I think is very interesting. And just as a point of interest to you, one of the things was discussing now around data donation and access donation. Imagine if you could turn the clock back to January and you were questioned as to whether you would share your contact information with public officials pre-COVID. And I think that maybe give you a little bit of food for thought. So would we have been so ready to exchange our contact information 6 months ago as we are perhaps now? Anyway, without further delay, I'm delighted to introduce my wonderful colleague, Karina Dantas, who's from Portugal, also works for Caritas Coimbra. I've known Karina for a very long time, and I'm very pleased to introduce her, which she's going to talk about the Digital Health Europe project, the Horizon 2020 funded project that we're involved with. Karina, over to you.
Okay, thank you, Andy, and thank you for the very kind presentation. I'm actually very excited to be in this follow-up because the previous presentations were really nice and interesting, and I think even with different names, we are all maybe going in the same direction. So I think I need access to share my screen. Okay.
Yeah, Joachim, you just turn off your screen, please?
Yeah, I think it's done now,
Lovely.
Is it?
Yeah, wonderful.
Okay. So as Andy already introduced, I am today presenting to you a bit of the work that we have been developing under the Digital Health Europe project. We have been leading a task which is directly connected to citizen control, data sharing, governance. And that goes along exactly what we have been discussing today. So we did start before COVID. We started before a lot of the policy papers that we discussed already today. So this was the background for the proposal of this project and even for the beginning of the task, which was already in the January 2019. So actually in a very few months, we have had so many differences in the landscape that we also had the need to evolve the task a little bit and to adapt it to current challenges. But this was the baseline, and when we started this work in this project, the feedback we had was that most of the people that were consulted in these two broad European surveys said that they felt they did not control their personal data online. They would like to give explicit approval for it to be used, and they were very suspicious about online businesses, and this includes simple things like social networks, email, and search engines. At the same time, and only 2 years later, we see that 93% of people think that they should be able to manage their own health data, and at simultaneously, most of them also believe that this is a good thing because it could improve treatment, diagnosis, and prevention of diseases. So there was the perfect storm set up to try to improve this management of individuals' own data, and then to be able to use it for research. So the work that I have been talking about inside this project started with a broad desk review, which we did in 2019, and then we continued the work by doing 15 interviews across Europe to understand what initiatives existed, what was the thoughts of the main experts in the area, because as you may imagine, when we discuss data sharing in the health panorama, we have a very multi-complex and broad landscape to explore. And one of the main focus that we were trying to aim was to understand what would be the possible implementation of initiatives that helped citizens to control their own health data. So one of the initiatives that we addressed were health data cooperatives, but not alone. And we tried to collect as much information as possible from the people in the field on what they were doing and how they were doing it. Departing from there, we thought that a lot of different and scattered information existed, but there was something missing because we were focusing more on expert opinion, but many of the challenges we encountered were more connected to the trust of citizens and to the mechanisms for them to be able to share their data. So we released a large survey. We had it open for around 3 weeks. We translated it to all the European languages and disseminated broadly. And we had almost 1,000 people answering. This was a very simple survey, and this will be one of the things that I will be sharing you today, a bit to explain what were the outcomes of it. And of course, a part of this also was discussed in several events, webinars like today, and in a very few days, so next week, we'll be finishing a report about the conclusions and delivering it to the Commission. So for this survey, what we asked was specifically if people knew who had access to their health information, if they were aware that this information could be interesting for research, with which kind of organizations they would be willing to share their data, if they would consider giving access to their health data to other people for the good of others, and if they wanted to be somehow rewarded for doing this. Here, I must say that for the purpose either of the survey as for the whole project, we were not focusing only on medical data, but health data understood as medical and well-being as a whole. So it also includes a lot of our personal devices that already collect some data. So this was disseminated mainly through social media. We tried to reach people who were representatives of the common citizen that probably don't discuss this kind of themes every day, exactly to understand how we needed to address this. And we got different answers per country. We had big participation from Belgium, Estonia, Germany, Italy, Lithuania, Malta, Portugal, and Spain, but we nevertheless got representation in all of the countries, and somehow we can at least try to extrapolate some conclusions from here. Of course, the maybe interesting thing here is that just by chance, the survey was released already during the COVID season. So it is interesting to understand if the results now were influenced by this or not. Of course, this is something we cannot know for sure, but in some things, maybe we can at least acknowledge that the heavy participation in very few days was also probably due to the fact that a lot of these things have been discussed during the pandemic. So maybe at least we can acknowledge that this is the right timing to discuss this, because people are interested in discussing it as well. So the age range that participated the most is between 26 and 55, but we still got some interesting participations from either younger people and older people, going from at least a good representation of different areas. And of course, males and females, I'm sorry to say, is more or less the European average on the population now, or at least on the active one on this type of questionnaires and surveys and on social media. So when we asked if people knew who had access and control of their health information, a lot of them didn't. So we are talking more or less around 57% of people who either don't know but would like to know, or have no idea. And the truth is that this is probably the first thing that we need to address. If we are only having attention of less than half of the population when we ask them to share their data because they have no idea where it is or who can access it, then maybe this is the first thing we need to see how we can address in order to encourage people to participate more in these kind of actions. Of course, at the same time, even if they don't know what happens with their data, they for sure understand that it could be interesting for research purposes, for common good, for investigating on diseases, medicines, etc. So this is already a good point, because at least there is the understanding of why we should ask for this or why we can ask for this. Now, what we need to understand is if they are willing to share it. In truth, a lot of people were willing, but they divide a bit the type of organization. We already know that asking this kind of question is also biased, but the truth is that there were very different answers to this. And what we acknowledge here is a bit what we also acknowledged from desk research and from the interviews. People are very willing to share their data with their GP, with the people, with the doctors and the healthcare providers they know. However, if you go for other types of organizations, even if they are organizations, for example, non-for-profit, or if they are commercial, but they do work on health and care, there you have a lot of hesitation. So this is also something that possibly would make a difference. And maybe if we can find a system where people know who they are sharing their data with, then at least for universities and healthcare providers, it will be possible to have a big load of data shared. And this is very important for research. Then if you ask if people were given the opportunity to give other people access to their health data to be used for the good of others, if they would do it indeed, you have a very good average, I would say, because it goes for 93% that are interested in sharing their data, although more than half thinks they need to analyze it case by case. When we compare this to the age distribution, we see that the age range that influenced more this answer were youngsters. So people below 25 were the ones that were very heavily interested in analyzing case by case whom and for what would they be providing their access to their data. On the other hand, although there are still some significant results there, you have a lot more of older people who are willing to share access to their data no matter what the case. So this is probably something that can also influence the way we can target any campaign or any information we should provide to encourage data sharing. The last question was, if you share your data in this way, would you like to be personally rewarded? And you have around a fifth of people that say, we don't need anything. And then you have a lot of people who want to know the results of this. So around 60 to 63% want to know what their data influenced, in what way their data influence the outcomes. So, for example, if I know that I am sharing my data for investigating a disease that I have, which is research results for my own disease, I would like to know what were the outcomes. And at the same time, even if I am sharing my data for any research studies, I would still like to know what were the outcomes of it. So this retribution is probably something that was needed to invest, and this for sure can be an area where we can try to provide some transparency. We see that the interest in having money as a reward exists, although it is low. And when we go to the comparison on the age range again, we have the main answers of the youngsters going on, research results for their own diseases, also, of course, to any research results, but a higher result also for an economic rewards. While if you go for the much older age ranges, there is a higher number of people who want to know about research results or nothing, but there is almost no interest in having an economic reward. So this is also something that could be interesting for future campaigns. As Bladin already said, we are now trying to put these results together and frame them a little bit and try to provide some inputs in the definition of how the European strategy for data is being influenced and implemented, because it refers specifically the question of the citizen trust and the importance of it to be able to comply with enough protection rules in order to allow people to share their data, and to other policy documents. And one that we were discussing already here today, which is the use of location data and contact tracing tools in the context of COVID. And indeed, what we need to understand, if we can pull this together, what is said there, which is that at the same time, we need to ensure that the person is completely respected in terms of their data protection rights, but at the same time try to find ways where this individual rights can be not an obstacle for common good. So going a bit to the first question of the chat room, and as I understand, maybe not very far away from Jochen concepts, although with different words. One of the outcomes of our research and discussions was to avoid the term donation in terms of data sharing, because on one side it's not dynamic. If I donate something, it's no longer mine. And the idea here was that probably citizens would embrace better a system where they could choose when and how they share their data. And this is a dynamic process. It's not something that you don't have anymore. You give and you don't have. On the contrary, it's something that you can have going out and coming back for different reasons and in different timings. And therefore, I think in the explanation, almost in the same way as Jochen was saying, but using a different wording, we would then prefer data sharing and try to organize the full concept from there. Of course, that in the context of COVID, it would be very important to understand how do we frame this with common good. And this is for sure a discussion that I hope we can follow up, even when discussing different tools that are being used or that can be used for the pandemic follow-up. As for the wishes for the future, and just to end, from all of this, we understand that it is indeed important to increase citizens' trust, awareness, literacy, and access. This is the only way for people to have this dynamic model where they can understand what happens to their data, whom they share it with, and how they can allow or not to be used. And we need to give them the tools to do this. And they need to be simple tools. We need to have something that actually works in different countries, but that is simple and applicable. Of course, this is always the blue sky dreams. So we need to aim for that, although we know it is not as simple as that. On one side, because the different citizen-centered models that we analyzed and collected are still very scattered. Some of them are still very initial, and they need to be implemented and tested. Results need to be collected so that we understand if they work well or not, what are the impacts and what are the sustainability of their business models. And on the other hand, we do still need to invest in interoperability and standardization. We hope that European health data space can be also a move forward. But for sure, there is still a lot of room for improvements. And we do hope that we take on this momentum of COVID to advance more on this area. So for the questions later, I'll just leave you with this thought. If you think about your health data, what would be the model that you would like to have in order to consider sharing it for common good? I think that's it. Maybe back to you, Andy.
Thank you very much for that, Karina. Very, very interesting. And it's really, really interesting to see actual facts being presented from surveys and a survey that's been funded and supported through the Horizon 2020 programme with the Digital Health Europe project. So thank you very much for that and all the partners who've been involved with that project. That leads us to move to a slightly different area around the field of data and data donation. And I'm very, very pleased to introduce one of our European Connected Health Alliance members, Orca, with Liz Ashwell-Payne, who, if what she doesn't know about mobile health apps and health apps isn't worth knowing. So without further ado, I'm going to hand over to Liz and ask you to share your screen and tell us how we actually enable data donation, please.
Thank you, Andy, and thank you for inviting me to join today's session. I'm just going to start my video there. Let me know if you can see my slide.
Everything's fine. Just make it full screen and we're on, I think.
So thank you so much for inviting me to today's session. As Andy said, my name is Liz Ashwell-Payne and I'm the Chief Exec of Orca. And Orca is predominantly pretty much obsessed with digital health and health apps specifically. And our mission here at Orca is to distribute high quality digital health solutions to patients and the public. And there was an interesting question that just came up in the chat box, which was about, do people realise when we ask them about sharing data that they could already be sharing data through health apps on their mobile devices? So that was a really well-timed question. And I think that the answer is no, they don't realise, but I'll come on to that in a moment. So our mission is all about distributing digital health and health apps to people. But the vision for digital health and health apps isn't just about distributing these products to people's mobile devices. It's about connecting the data and being able to share or donate that data within the system so that we can truly benefit from this amazing breadth and depth of data that we all hold in our mobile devices. And just a really interesting stat really, if any of you wear a wearable like a Fitbit or a Garmin, and you go and visit your GP, your primary care practitioner, and you have 10 minutes in consultation, your wearable device will gather more data about your health than the healthcare system will ever hold about your health. And that's the tsunami of data that we're talking about here. The data that we each hold in our hands or in our pockets in digital health apps and the opportunity that that brings. And I just really wanted to do a little bit of a deep dive into what the size of this opportunity is. The reason we have a lot of this information that I'm going to share with you today is because Orca have been unlocking this power of digital health for coming up to 5 years now, and we work across 10 countries. We work very much within the NHS. We have a population coverage of about 45 million. And so we've gathered a lot of information that I'm going to share with you today. Now, what is the size of the opportunity within digital health and health apps? So currently on the marketplace, You may already know this, that there are over 365,000 health and fitness apps on the App Store. And every single day, 5 million people will download a health app. That's increased significantly by about 20% since COVID has arrived. And I think it might have been Blevin that mentioned this, that more and more people are now using health apps to monitor and manage health in a way that they weren't necessarily doing before. So lots of people are downloading these solutions. And there's a whole load of other stats here, but the one I just want to take you to is the percentage of healthcare professionals that also think that these solutions could help their patients and who may be interested in gathering some of the data from these solutions. And that figure sits at about 93%. So over 90% of healthcare professionals think that these solutions could help their patients. And as we know, we've all bought these smartphone devices. There are now more smartphone devices on the planet than there are toilets or toothbrushes. So we've bought the infrastructure to allow us to use these solutions. Just a little bit more of a deep dive into what that landscape looks like. It's actually changing. And so a couple of years ago, the majority of the marketplace for digital health sat in wellness. And what we've seen over the last 2 to 3 years is a significant increase in products available to support health condition management. And that's really important, particularly during the pandemic, where people living with long-term conditions or who are shielding may want to use a solution to help them manage their health condition. So we've got a huge opportunity. Now, if we just drill down a tiny bit further into those health condition management tools, this is what that sector looks like. To give you an idea of volume, that 28% looking at mental health conditions, which is obviously a big area of concern for a lot of healthcare systems during COVID, that 28% represents around about 20,000 digital health apps. So we're talking about a huge opportunity here with these solutions and obviously the data that sits within them that we're all using on our phones. So the next obvious question, once we look at the size of this opportunity and the size of the data tsunami within this opportunity, is, well, why haven't we used these solutions? And why are we not able to gather the data out of them? And really what I'm going to talk about today is the main barriers to adoption and what the enablers are to enable us to get the data out of these solutions at scale and pace. We'll all know of some very small pockets of work where a product has integrated within a data environment. But how do we do this at scale to really seize that opportunity? So the first thing is, what are the main barriers to digital health adoption? Well, the first one, very simple. People aren't aware that these solutions exist. So if you go out into the street and from a social distance ask somebody, did you know that there are digital health solutions that could help you with manage your COPD, asthma, dementia, etc. Most people don't know that there are solutions, and that actually isn't just our populations, that's also our healthcare professionals. And that's my background. I worked in the NHS as a healthcare professional for nearly 20 years, and I know that for colleagues, their awareness of what is available is pretty low because it's not embedded into our training. The next barrier is access. Okay, so we now know that there's this opportunity, but where do we go to get these things? We can't just pop to the shops. And unfortunately, the app stores don't work in health, fitness and medical. And the reason they don't work is because they don't address the searchability opportunity. So if you typed in a word like COPD, you'll get very few results found. Something like dementia, no results found, even though there are over 6,000 products. Now, the ultimate challenge is trust. And this trust isn't unfounded. Our research has found that only 15% of digital health solutions actually meet the quality criteria that you would expect. And that quality criteria is really important for data sharing or data donation. So if we don't know whether a product is going to hold our data securely and adhere to data privacy regulations, how can we trust it? But also, how can we trust whether it meets clinical regulatory requirements? And obviously, medical device regulations is one element of that, but there are a whole suite of other regulatory requirements. So that trust is really the ultimate barrier to us being able to use these solutions. And then the fourth challenge is ongoing risk management, and I've called that governance. Now, these solutions change all the time. Their business models change all the time. If an app is able to hold data secure on day one, but by day 3 they've changed that and it's no longer holding data securely, how do we track that? How do we monitor and manage an ongoing quality assessment to enable that trust to be delivered? And it is that trust that it's at the heart of this. And if we're really going to do this at scale, how do we engender trust in the system? And as I said right at the beginning, Orca's mission is all about distributing high quality digital health solutions. But what we are most known for actually is for reviewing and approving digital health solutions, either independently or on behalf of government bodies, both in the UK and across Europe and further afield. And that review is absolutely critical in being able to know whether a product is safe and can be trusted. Now, what we do is we don't just review a product once. We've built a system that allows us to survey and monitor changes in the landscape of digital health apps. Every time the product changes and updates, we re-review so that our review is a live review that can be trusted on the day of viewing. And that viewing is really important. So once you have established which products can be trusted from a data security, data privacy, and obviously clinical validity perspective, you then need to tell people which ones are good, because as I mentioned earlier, we're seeing 5 million people download these solutions every day. And what we absolutely know is, unfortunately, they're not necessarily downloading good quality products, which then means we're not able to leverage the benefits from these solutions. So what we then do once we've got this repository of reviewed information about the digital health world is we then put this information into locally targeted and locally branded health app libraries or digital health formularies. And we have over 500 of these now. These digital health libraries are promoted to populations so that populations now have a safe place to go to search for, find and use high quality products. These libraries are engines which are built on specific health and medical criteria. So it's not just about finding a long list of solutions that are good and high quality, but it's also about finding the best solution for you on a personal level. Let me just give you an example. If, for me, I have 2 children and a husband, if we're all feeling anxious during this time of the pandemic and I go on to a digital health library to find my teenage son a solution for his anxiety, you can bet that he's going to want a different solution to if I want to find a solution to help myself or my 6-year-old son. And that's only using one difference in demographic profile, our age. You then layer in different requirements such as hearing impairment, visual impairment, technical preferences. And what we see is actually the need for an ecosystem of digital health solutions that need to be promoted to a population so that they can find solutions which meet their personal requirements and meet the quality criteria to engender trust. And this is really important. And one of the ways in which we're working at local level, so we have these digital health libraries at national level. So the one on the right-hand side is the Netherlands Digital Health Library, and the one on the left is a local app library for South West Yorkshire in the UK. But what we're doing at national or regional or local level is we're adding in layers of assurance. And from a data security and data privacy perspective, we're adding in layers of review which enable the innovator to know what the rules are to play in that ecosystem to enable true data sharing at scale and pace. And so what we do is everybody has access to the 6,000 reviews that we've already undertaken. And if a region or nation has specific rules for innovators to play within that ecosystem, we're very clear in knowing which ones meet those rules, or in fact sharing what those rules are to the innovator community, so that this ecosystem can truly thrive and be received at a personal level. Now, what we do with these app libraries is we then work with healthcare professionals who have touch points with the target population. So if you're a doctor and you want to use this to not only find a solution for your patient, you can find it and also use this as a formulary to recommend a product to your patient. And that recommendation happens by a text message. And this is really important for that ongoing risk management. If the system knows what products have been recommended to which patients, and that product changes in the future, we can do a recall and push a quality solution in place of that recommended tool. Now, what's really interesting is I've talked you through 3 steps to enabling data sharing and data donation at scale, which is first step, accredit, know which products are good. The second, promote that information, tell people which ones are good. The third is activate and integrate. So make sure that your healthcare professionals know how to use a library to recommend solutions to their patients. But a fundamental step, which was great to hear from German colleagues, is this formal prescription and reimbursement of the solution. So it's not enough to just recommend a solution to patients. We have to create an ecosystem which allows for reimbursement and formal prescription. And it's fantastic to hear about the work and the laws passed in Germany, because without that last step, we can never expect this ecosystem of digital health solutions to be able to share the data out of their products, because they need a sustainable business model to allow them to thrive in this marketplace. Now, what I just wanted to quickly touch on was how this landscape can really support us during the COVID pandemic. And you can see here on the screen a whole range of areas, including COVID-specific track and trace products, but also how we can really leverage some of the opportunities of digital health right now. So again, people living with long-term conditions, people who are pregnant. It's a challenging time to be pregnant at the moment, and being able to provide online consultations, symptom checkers, physiotherapy, etc. And I think that what we're seeing is a significant increase in people wanting to use digital health solutions, but the true way to activate them is to enable them to have trust and know which ones they can trust. Now, what we did at Orca when COVID hit was we stopped doing all work, and we went into our repository of reviewed and rated solutions and put them all together into a COVID health app library, which is freely available, and you can go and have a search and look around this app library to find out which products are safe and can be used at this time. The URL is there for you to use, and if you are a healthcare professional, you can request the ability for that upgrade code to be able to now recommend solutions through this system. What's been really interesting is just tracking what people are searching for in this library and across all of our libraries since COVID. So the first thing to say is we've seen a significant increase in people coming to these app libraries. So we've seen an increase of 180% of visitors across all of our app libraries. And what's really interesting is the recommendation increase. This is doctors, nurses, therapists now using these tools to recommend by text message products to their patients. It's increased by 6,500%. And our activation rate is about 71%. So 71% of people receiving a recommendation will download it. But what we haven't obviously got within our system is this reimbursement model, which is so critical. Now, what we also saw was a change in what people were searching for. So right at the beginning of COVID, people were searching coronavirus, COVID-19, etc. After a couple of weeks, we then saw a significant increase in search terms around diabetes, COPD, asthma, pregnancy. And now what we're seeing are search terms around fitness, exercise and mental health terms. And it's been really interesting to track some of that data to see what our populations and healthcare professionals are searching for during this pandemic. So just to reiterate, if we're going to truly unlock the data out of these digital health solutions, we have to think through all 5 of these steps. There needs to be an accreditation or approval system. Once we know which products are safe, we then need to tell our populations which ones are good and activate patients through healthcare professionals. We also have to work with healthcare professionals to help them know which products work best at what point in the pathway, so embedding these solutions into care. And that final step, which is absolutely critical, is the economic sustainability and that reimbursement to keep this marketplace alive and thriving. Thank you for your time.
Thank you for that, Liz. Very interesting, as always. Just a quick question before you're off. We had a question in the Q&As, which I just touched on now. Do you get many tracking apps in your library, or are they are they sort of classic health apps?
Yeah, no, we've been reviewing COVID track and trace products, and I think that what's really interesting about track and trace products is they've obviously been developed very quickly in a rapid response to the crisis. And if you look at some of the regulatory requirements for digital health solutions around data security, data privacy, clinical validity, that might normally take years to get through some of those regulatory hurdles. So what we've been doing is working with those product innovators to help them through and navigate them through that regulatory minefield. But we've also been quite clear in talking about the risk and the reward. So right now we can get, as populations, get a huge amount of reward, but there might be some potential risk. And what we do at deployment of this information, you can see it in the COVID app library, is we always list what the side effects are of those products. So if a product hasn't gone through peer-to-peer review or RCTs, well, it's pretty obvious that it won't have done because it's had to be created quite quickly. But we list what those side effects are, so at least people can trust in the knowledge that they have, and they can be empowered to make their own choice.
Thanks for that. Thank you very much. Great to hear, as always, from Orca. Now we're going to whiz very quickly over to Finland, where we believe they're having a heat wave. And I'd like to introduce and welcome our European Connected Health Alliance member, VTT, and in particular a warm welcome from me for Kari Kotamaki, who's very kindly agreed to talk today around data donation landscape, which is, and give a Finnish perspective. So Kari, over to you.
Okay, thank you so much. Okay, so my name is Kari Kohtamäki and I work for VTT. And VTT is a non-profit research organization based in Finland, and we have a bit more than 2,000 researchers in different fields of technology. We originate from Finland, but actually almost half of our turnover today comes from abroad, from companies, public sectors, and donating organizations. Our focus in the field of health can be seen from 3 perspectives. We develop solutions for preventive health, predictive diagnostics, and healthcare process optimization. But today I'm not focusing on VTT's own research results, rather trying to outline the landscape for data donation or data sharing in Finland. I will tell you something about the basic elements for storing and sharing data in Finland, something about existing legislation, enabling sharing of data, and finally a few thoughts of how data sharing or donation in practice would work and how we can help it happen more frequently. So first of all, Finland, data donation as such is fairly widely accepted in Finland, and there are a few reasons for that. First of all, let's say this may be part of the what we can call the Scandinavian culture. People in general appreciate health and wellness very highly. They are high values for Finnish citizens. Also, we consider us to be a welfare state, perhaps fortunate ones with well-functioning social and health system, and it includes a component of solidarity, which is very important for people to share data. Population is fairly well educated, which helps in convincing people about the importance of this issue. And contrary to many countries, there seems to be a high trust on authorities and public sector in Finland. And my final point is there that there is a tradition of donating, like donating blood, donating organs, donating data, as we have heard today, is a little bit different, but it belongs to the same family. Now, very briefly, as time allows, a few basic elements of our data infrastructure, enabling data sharing. The central element is the patient data repository, which we called Kanta. And it kind of collects data from different EMR systems around the country, puts them in the safe one storage, and provides access to professionals across the country to access it. But I have highlighted it with orange that patients have a big power in providing consent to that data. They can also withdraw the consent and refuse to share the data. So then additionally, as I mentioned, donation of organs or even having a living will eventually are declarations of intent that are stored in the same data repository. And part of that Kanta archive is actually the My Kanta personal health record, through which citizens have access to their own health data. They can see their patient records, but they can also see their prescriptions and so on. The newest member of the family is actually the My Kanta PHR, where citizens can actually store their own data, own measurement data, or own observations of their well-being. And again, the users may give consent to caretakers to look at the data. They can also decline it, but there are rules by which there has to be a treatment relationship between the citizen and the doctor, so that the doctor can see the data, and the professional application must be authorized for the PHR. The other element in addition to Kanta service, this central repository, is the biobank system. And this is growing very fast. Again, here we have something like 10 different biobanks in Finland, and anybody in Finland can donate their sample and the data to the biobank if they want. With this access, this data can be used to connect it with different hospital data for research and clinical care. And this picture tries to summarize our objective of combining these different data sources together. So healthcare data from hospital repositories, people's own data, and the biobank data for providing affordable, high quality cost for everybody. Then I wanted to give you one example of VTT's work on this in this field, and we have been actively participating in the project for prevention of diabetes, type 2 diabetes in Finland, called Stop Dia. And this example is illustrates how different parameters from self-reported data to genetics to metabolomics to wearable sensors and questionnaires can be used to profile people with the risk for diabetes. And the outcome, as you can see on the lower right corner, is that we can actually segment people based on their risk level and expected response to actions, so that some people simply are fluent with digital tools and just utilize an app and get help from that. Some people want to have peer support, and then there are many who really need face-to-face contact by different coaches. As an outcome of this project, we have created an application for providing advice on actions for people at risk, how they can prevent the likelihood of the disease, and also some tools for profiling people according to their personal profile, according to their readiness for change and the need for change. Okay, but to conclude, data donation in practice, speakers before me have already mentioned many of these. What is needed is, first of all, the awareness, obviously, of the, in this case, I mean, awareness of the importance and possibility to share data. Motivation, it's not just important to know about it, but to understand why. And a reference to COVID in the sense that it brings the urgency to our minds, and we have noticed that this definitely increases the motivation of people to share their data if it's meant for improving ways to take care, diagnose, and take care of the virus. Well, without tools and infrastructure, obviously nothing is possible. So that part needs to be taken into good condition. And finally, the trust must be there. Rules of the game for privacy, security, and so on. The latter point, who do we then, who benefits and who do we trust? It's maybe more like a provocative statement there. Do we trust on common good by public authorities? Do we trust on and want to benefit the science through medical research? Or maybe we just want to have access to good services, which then leads to technology providers having the data. And some people, of course, may trust nobody. My final points are here. How then, because we feel that it is obvious, I think we all agree that it is very important for the science, for the research, for the clinical care to share and donate data. How can we make it happen? So one thing is transparency. People need to know what happens to my data, who gets access to this, and why. Regulation is important for privacy reasons, as mentioned. We have GDPR and other regulations in place, but it should not be prohibitive, or it should not be too much bureaucratic. Culture of sharing for common benefit is something that we would like to nurture. People need to understand that helping others is helping me one day as well. Public investments to put the data infrastructure in place. There are different ways of approaches. We had about the German approach. I have told you something about the Finnish approach. But in any case, it should be a public investment. And finally, communication, motivation to people. I mean, we may have wonderful infrastructure for people to share data, but if they are not aware of it, as we heard from Liz, if they are not aware of it and they do not understand the reasons why, then the money goes wasted. So these are the final points from my side. Thank you very much.
Thank you very, very, very much, Kari. And yes, Beyond the Obvious is a nice title to end with. And I think certainly from today's conversation, we've ended up at the issue of trust, and we've seen different perspectives from all of our speakers today, and they've been I'm very grateful for their input and valued time. Trust, though, remains the issue, and it's odd. One of the things we've not seen today is any discussion on what data people share personally via social media, and how that's governed in terms of their symptoms and how they're feeling and their stress levels. And so that's quite interesting. But thank you again. All of our speakers have been very, very interesting. And I think, it's been great. One of the great things about today's session, and I think we've answered pretty much all of the questions there, but one of the nice things is we've seen input from across our network. The network that brings together inputs from the Digital Health Society, and thanks to Bledin Rees for that input there. We've seen input from our ecosystems in Germany, and thanks for your input, Jochen, there from Medical Value, our newest German ecosystem. And we've seen great input from our European funded programs and projects, the Digital Health Europe program. Thank you, Karina, for your input there. And of course, from our members. And so we've seen some fantastic different examples from Orca. And I think some really, really good questions there for how people are going to use digital health apps ongoing from today. And then lastly, from Finland, to see, and great to see Finland taking part now in our data, in our pop-up ecosystem. So thank you all warmly from myself, and thanks to my colleagues Bayer and Heather for helping out with this. And we've just about finished on time. So without any further ado, I'm going to say thank you and goodbye.
Bye-bye.
Bye-bye.
Bye, everyone. Thank you.
Thank you.